So let's have a look at the MCQs of spine and lower limb trauma. Identify the angle of scoliosis. There's only one angle that you should remember, the Cobb's angle. A patient presents with scoliosis, X-ray shown below. So this was an X-ray that came in name number 19, and it talks about congenital scoliosis because you can see there is a structural abnormality of the vertebrae. Which of the following is not a part of the middle column? So what is anterior column? Anterior half of the vertebral body, anterior longitudinal ligament, anterior part of the annulus fibrosus. The middle column, posterior half of vertebral body, posterior half of fibrosis, the annulus fibrosus, and the posterior longitudinal ligament. Ligamentum flavum is a part of the posterior column. So this is the answer here. Question number 4. Which of the following is correct? Hinge fracture is separation of anterior cranial fossa from posterior. Absolutely correct. It's also called as a motorcyclist fracture. All are true regarding Jefferson fracture except C1 and C2 injuries usually do not have neural deficit because it's a very capacious area. So the early neurological involvement will not be there. We know that Jefferson involved the atlas, lateral axis is useful, both anterior and posterior arches involved. Evaluate the following statement with regard to intertrochanteric fracture. Now, when you have this type of question coming in AIMS, you need to read all the options. More common in male than females. Let's see what exactly it is. We will see again. 1 year mortality rate is 20 to 30%. Correct. And you can reduce the mortality if you do within 48 hours. Correct. So B and D are correct. Coming to C. It is more commonly associated with non-union than fracture neck of femur. No. It is more associated with malunion. Fracture neck femur is more associated with non-union. This is wrong. Now look at the options. C is wrong. So C is not there. C is not there. C is not there. So answer automatically is B and D. We are not sure about A, but even then we can come to the answer. B and D are correct. Remember that. Question number 7. This is rail fixator. We had a word. Question number 8. With patients standing on the right side, opposite hip drops. So drop of the opposite side of the pelvis is positive. What is affected? Same side, superior gluteal nerve. The given X-ray is showing there is involvement of the ipsilateral anterior posterior elements called as Melgagne fracture. A child brought to the emergency with a femur fracture. He is confused, dyspneic, rash over the body, fat embolism. In this question, some people say they had mentioned more than 48 hours. Some say within 24 hours. Doesn't matter. This is classical fat embolism. True about the fracture shaft of femur. More common in elderly. False. More common in young people. Managed with elbow traction in elderly. Gallows traction is usually for less than 2 years. False. Associated with pulmonary complication. True. Fat embolism is one of them. Intermittent nailing is gold standard. True. Interlock nailing is the gold standard for long bone fractures. Upper limb bones are usually plated. Lower limb bones, nailing is done. Open injuries, external fixator. Children, conservative. Match the eponym with their fractures. Trimallar ankle fracture is Cotton's. Comminuted depressed fracture of the lateral tibial condyle. Comminuted depressed fracture of lateral tibial condyle, no name is there. This is bumper fracture, so it's not there. Comminuted interarticular fracture of distal tibial and pylon fracture. Fracture lower end fibula, runner's fracture. Intra-articular oblique fracture of stellar process of radius, Schoffer's fracture. Bimalar fracture is Pott's fracture. So fractures, their eponyms and the names should be on your tips. Nerve injuries on your tips. Very commonly they can be asked that match the following. True regarding fracture of neck of talus. Displaced fracture requires open reduction internal fixation. True. Displaced fracture requires a cast. Wrong. Lateral view can help. True. Avian of the body can be there. True. So these are 3 true. What is the use of the given instrument? It is plate and bone holding forceps. So it will be used to hold bone and plate. The instrument shown in the image below is a bone nibbler. So I told you, bone holding forceps, bone plate holding forceps, and nibbler, very commonly asked. Deformity seen in posterior dislocation of femur. So when you talk about posterior dislocation of hip joint, you will have flexion, reduction, and rotation along with shortening. Fardir and shortening. First, reflex to recover after spinal shock. Bulbocavernosus, we'll have a short word about it. Normal curvature of lumbar spine, lordosis. What is the preferred method for treatment of fracture patella? Tension band wiring. This came 4 times consecutively in AIMS. March fracture involves the neck. Remember, it's not the shaft, not the base. Length and interval limb in a person with fractured neck of femur. Shortening and external rotation. 23-year boy sustained an ankle fracture while playing badminton, after which a plaster was applied. After the plaster was removed, his pain persisted. His mother gave him a massage. He felt pain in the calf, developed breathlessness, tachypnea, rushed to the emergency, collapse, could not survive. This is pulmonary thromboembolism. Remember, if you have a surgery after 48 hours breathlessness, this is usually pulmonary embolism. If you have an immobilization by a cast, some pain, vigorous massage of the calf or anything, collapse, dyspnea, pulmonary thromboembolism. But if you have a fracture shaft of femur after 48 hours breathlessness, this is fat embolism. Classical histories. Patient presented with RTA, flexion, abduction, externation. This is anterior dislocation. What is the most likely mode of injury of vertical fracture medial malleus? Adduction injury. We had a word. Supination adduction injury, vertical fracture of medial malleus. Runner's fracture, fibula. A patient has a history of RTA, complains of the pain of the hip, young man. There is flexion, external rotation of the left lower limb. 7 centimeter shortening. So there is shortening, there is flexion, external rotation. There is a gluteal mass. So with a gluteal mass that moves with the movement of the shaft, it is a posterior dislocation. Posterior dislocation should have shortening, that's okay, but shall have fardir. So it does not have fardir, and there is a gluteal mass. Gluteal mass, central is out because it should be parrectal, anterior is out. Shortening with a posterior mass, 2 options. Classical fardir, posterior dislocation. If not, atypical presentation, Pipkin's type 4. So if in the history fardir would have been there, it would have been posterior dislocation. But there is external rotation. So atypical presentation, fracture dislocation, called as Pipkin's type 4. Very, very difficult question. A 60-year-old female, there is extension, external rotation. 60 years. Think of neck femur. 80 intertrochanteric if no other point is conclusive. So intracapsular. Again 60 year. Trauma. Ecchymosis. There is extension of the leg. Lateral border of the foot touches the bed. Classical history of intertrochanteric fracture. Extracapsular. Extra, everything extra. Same age, but here the clinical feature goes towards extracapsular. Less than 45 degree. Neck femur. Complete rotation, intertrochanteric. Patient presents with normal Babinski reflex, with ankle areflexia, with presence of saddle anesthesia and difficulty in micturition. So there is neural deficit with bowel bed involvement. After some problem in the spine, cauda equina syndrome. Look at this flowchart. Any spinal injury, total areflexia, no motor, no sensory. This is spinal shock. The end of spinal shock occurs with the return of bulbocavernosus reflex. This was a question that we did. Then, if there is a terminal injury to the end of the spinal cord and the spinal shock is over, if it's a symmetrical loss with bowel bladder involvement, it is conus medullaris. The terminal end of spinal cord is called as conus medullaris. It will lead to symmetrical loss. But when the nerve roots are damaged, it can be asymmetrical, called as cauda equina syndrome. Saddle anesthesia is the area around the perineum, around the perianal area, which comes in contact when you sit on the saddle of a horse. It is classically seen in conus medullaris, can also be seen in cauda equina syndrome. And then a patient present in orthopedic department with scoliosis. Which test will you use? Adams forward bending test to differentiate the two. So this was about trauma. Remember upper limb trauma? Number one. But nowadays spine, a lot of questions are coming. Thank you.